The basic objectives is cranial cavity. We have different objectives here. Bismillah. Skull and vertebral column. So most of the vertebral column you know now. I have told you with the spinal cord. So I will have a quick revision, and if there is an extra slide or you have some problem, you can stop me. Otherwise we can fly. Number one. Number two, describe anatomy of the norma bizalis interna cranial cavity. So basic objective is cranial cavity, but why I am using the same slides? Because identify foramina, fissures and canals of the skull. Not only cranial cavity, all the skull. So I should, if you don't know where is the sphenoid bone, how you know there is a foramen or a sphenoid sinus? So a quick revision of some important landmarks and then the foramen and fissure. This is my planning. Anterior and posterior fontanella, this is probably the new thing in, was not there probably, fontanellas. And define vertebral canal, and you know most of it. So, Bismillah. What is skull? If we have this complete set along with the mandible, this makes the skull. Okay? If I remove this thing, this is called vault. If this is removed, you see, this is called vault. Vault. And after this, you find this cranial cavity. This is cranial cavity. How many parts? Norma verticalis from the top. If you see, frontalis, lateralis, basalis, and occipitalis. Okay, nothing new here. So very easy to go through the. Okay, let's have a quick revision. Frontal bone, this is the front part. Okay, frontal bone, 2 parietal bones and 1 occipital bone, connected with sutures here, here, and here. Can someone name some sutures? This one.
Sagittal, corona. Sagittal.
Sagittal corona. Sagittal coronal. What is this?
No, this is corona.
This coronal. This.
Sagittal.
And this.
Lambdoid.
Lambdoid suture. Very good. So we have a certain sutures: coronal, sagittal, and lambdoid suture. And here we have a parietal foramen here on the parietal bone, parietal foramen. What it should get out or get in? This is the top of the skull. What do you think it should have?
Veins.
Very good. Some veins of the scalp, emissary veins which drain into the inside the skull. Very good. Okay, valves now. Vertex. What is vertex? Vertex is the highest point on the skull. If you see, the vertex is the highest point of the skull. This is just a definition. What is vault? This structure, if I remove from the skull and leave the cranial cavity behind, this is called a vault. Then, the junction point of this here, this junction point here and junction point here between the two sutures, coronal and sagittal, is called brachma. And here this is called lambda. These are just the names of the sutures. Okay. Leave this slide. Even leave this. There are certain bones here to identify. Sometimes you are asked frontal bone, parietal bone. This is on the side view. Frontal bone, parietal bone, occipital bone. Then we have all this temporal bone with two important processes, styloid process and mastoid process. Why important? Because in between them there is a foramen, stylomastoid foramen. Stylomastoid foramen. I will show you. There are certain things which I can show you here. There are certain things when we will finish, I will try to focus on the foramens individually here, inshallah. Then we have sphenoid bone. Some of it is visible here and some of it visible inside the cranial cavity. I will show in another image. This is zygoma, zygomatic bone. Here is the nasal bone. Here is maxilla. Maxilla, and this separate bone is called lacrimal bone. Lacrimal bone. I make a star. And this is mandible. Okay? I think nothing hard or difficult here. Yes. One of the important things, structures here is Tyrion. H-shaped suture. When I say H-shape, it is like this. H-shaped suture, Tyrion, between frontal, parietal, sphenoid and temporal bone. So this is an H shape. The most important structure on the lateral view, or the most important suture here, is this. What is the importance? If you have a fight or if you have a fall on this side, this is the likely area to be injured. And the problem with it is it has anterior division of middle meningeal artery just beneath it. So whenever there is a trauma, fracture or anything, this is likely to bleed and cause an intracranial hemorrhage. So one has to be very careful about this Tyrion. T is silent, we don't speak pterygon, no, Tyrion. Then we have zygomatico-temporal suture, where it should be ideally, this is zygomatic bone, this is temporal, zygomatico-temporal, and it makes an arch-like structure. Arch is clearly visible here, even palpable. Okay, this is zygomatic arch. Yes, here we have superior and inferior temporal lines, and with this arch they make a temporal fossa. After that we have an infratemporal fossa, which is just below this area, infratemporal fossa, and then we have another pterygoid fossa. Here is the boundary for infratemporal fossa, infratemporal fossa. Why I am saying you all these structures? Because now I am going to jump on these openings and foramen and fissures. So just to make a preface, this is pterygopalatine fossa. Yes, here is one of the important objectives. Fontanella in the skull. What is fontanella? Fontanella is a soft area or a soft spot. How it is made? With the help of membrane. It's a membranous gap between the skull bones. Why it is there? When these bones, in the fetuses and in the newborns, there is a gap between the bones of the skull. There are multiple gaps. One of them, the biggest one, is called anterior fontanella. Where it is? Here is the frontal bone, here is parietal, here is another parietal. So between them, it's a diamond shaped space that is present here, and this is membranous at the birth, for example. What is the purpose? The most important purpose is the molding of skull for birth canal. Vagina is a small tube. The head of the fetus has to cross all through, leading the whole body behind. So, what is molding? Actually, this is the process of molding. This is the process of molding when the shape of the head becomes a bit oblong, and it is able to pass through the vaginal canal at the birth time. This is the most important use of these fontanella. Fontanella allows stretching and molding during childbirth. Now it's clear. Facilitates the brain growth, and when they close, as the time passes with the age, as they close, they make the sutures. So here, this parietal will come, join this parietal bone, and there will be a suture, and you know the details of the sutures. I have just done for you. Anterior fontanella is the largest of all available fontanella in the skull. It is diamond shaped. This is the size. At the junction, many of the books says at the junction of coronal and sagittal suture, because I'm not comfortable with this term, because there are no sutures at this moment. So the best way to explain is between frontal and two parietal bones. So this is the gap area. Closes, you should remember these closure times, 12 to 18 months. Since this is the largest and this is the most available, mostly available till 18 months. So we have some clinical importances along with a general importance for any fontanella. What are the general importance of any fontanella? The molding, the stretching, formation of growth of the brain. Molding, sunken. If this fontanella is depressed, then it is indicating a dehydration status in the child. Elevated, raised intracranial pressure. It will be up, elevated. Some book says excessive crying or prolonged crying can give you elevated. And late closure is associated in cases of hypothyroidism, since thyroid has some role in metabolism and bone growth. So here are certain conditions. you can see molding here. You can see a depressed fontanella. You can see a depressed fontanella indicating some degree of dehydration in the infant. Plus, you can see here elevated fontanella, suggesting some intracranial raised in the intracranial pressure, suggesting some intracranial tension. Okay. Again, I repeat, this is the biggest and the most prolonged available clinically fontanella. Up till 18 months, I can have some clinical examination. So this is the most important one. Another one on the back here, on the posterior aspect, here is triangular in shape, is called posterior or occipital fontanella. We called one as fontanelle, multiple as fontanelli with E, okay? I write here. Then at the junction of sagittal and lambdoid here, sagittal and lambdoid suture. I'm again uncomfortable with this term. Rather, I should say between two parietal bones and the occipital bone, this is the gap. So this is what posterior fontanella is. Of course, molding of the skull, usually it's a very small one. So why to miss the big one in front and go for a small? But still you should remember that it closes around 2 to 3 months of age of the baby. There are two other small fontanelli. Here one mastoid and here one sphenoid. Where is mastoid? Between parietal bone and mainly the mastoid. This is mastoid fontanella. And here between the parietal and the temporal, sphenoid bone here. Parietal and sphenoid bone, sphenoid fontanella. They are small. They are less important clinically after birth, but still for molding process they are helpful, of course. The mastoid fontanella is located, this is the location, closes at 12 months. But since we have a available big fontanella here for 12 to 18 months, so we can sometimes even not palpable by the novice doctors. Sphenoid fontanella, here is the location, I told you. Closes around 6 months. Both of them, they are smaller in size. Molding, yes, but after birth, the clinical significance for anterior is the most, then posterior and then. Okay, here is the base of the skull, norma bizalis. Why I'm telling you norma bizalis? Because there are multiple foramina here, like this one, here, here. We'll see them. Anterior part roughly at this level. Middle part roughly at this level. Here. And the posterior part after foramen magnum, including it. By the way, what passes through foramen magnum?
Lower part. Lower part.
Brainstem and spinal cord.
I was saying lower part.
The lower part, medulla oblongata and
Anterior spinal.
And posterior, of course. Anterior and posterior spinal arteries, of course, good. And meninges, very good. Meninges, CSF, everything. Except the esophagus. One of the students wrote esophagus in exam, so please don't write. This looks good for the passage, but it never has esophagus in it, okay? Be careful. Okay. Alveolar arch. This is what is called alveolar arch. This structure. This is alveolar arch. It contains sockets. Socket is an empty space where the teeth can fix. So this is alveolar arch. Here is the maxilla bone, then here is palatine bone. And the sutures, you may leave them. What is important here for you is incisive canal. I have labeled all the content of the foramen in the later part of the slides. Here I wish you to identify them and the contents you can later on remember. Here is the incisive canal. Here is a greater palatine foramen and smaller or lesser palatine foramen. These are on this is hard palate. Hard palate, this is again hard palate. And if I go in a normal person, not a cadaver, on a living subject, after this is the soft palate. Okay. So these are the important here. You can also find them here. greater palatine and lesser palatine. Okay, these are the available foramina here. In the median area, we have a big opening like this here. This is a big opening. This is the back of the nose. When I say back of the nose, here is the opening for the nasal cavity, anterior part. Okay. On the body surface, I have nares, opening, nares, leading to this part of on the skull. On the back, there is again an opening, and this is called as choana. This is called as choana, right and left choana. Can anyone name this bone?
Femur.
Vomer bone, excellent. Vomer bone is one of the bone which makes the septum of the nose. So here is vomer bone, and if I go in front and see here on front, there is a perpendicular plate of ethmoid bone. Here is the ethmoid bone. I am coming to it in a minute. Then the lateral areas, we have other bony parts. Let's see. Sphenoid bone, yes. This is a crowded slide. I'm sorry for that. Still, we can identify a lot of structures. Choana, just lateral to it, I have here a thick part of the bone known as pterygoid process. It gives you two plates, a medial pterygoid plate and a lateral pterygoid plate, and in between them is the pterygoid fossa, and this is concerned with the muscles of mastication. Okay, medial pterygoid plate, lateral pterygoid plate, in between them is the pterygoid fossa. Another structure which you can identify greatly here is this one, the yellow awl, greater wing of sphenoid. Why I am going to greater wing of sphenoid? Because it is having many small openings and in it and in the associated bone. Yep. Foramen ovale, you should remember the smallest in this region is spinosum. So S small s spinosum. Make your life comfortable. S small s spinosum. Oval, only oval available here, like oval shape is ovale. So oval ovale. Then on the medial side, lacerum. It should have some name with M, but I'm sorry, it's lacerum. If this was M, it was a perfect match for a smallest spinosum. Then we have ovale, oval, foramen ovale, and then we have lacerum on the medial side. In the same picture, you can see here carotid canal and a jugular foramen. Okay, what is carotid? What is difference between canal and a foramen? Anyone?
Foramen is just an opening, communication between two spaces. A canal actually has walls.
Good. If I have, this is a part of the bone, for example. If I have a through and through opening, straight forward like this. Here is an opening, the same opening visible on the other side. This is a foramen. Canal, like one of our colleagues said, I'm thankful. Canal is maybe a tube-like and maybe like twisted, or so carotid canal is like entering here and there is no opening here on the same plane. The opening is in front. So you may miss the opening of carotid canal. So the canal you can see here, but if I pass a wire in it, it will open like here on the inner side. So this is the difference, a difference between foramina and any canal. Am I clear?
Yes.
Are you with me?
Yes.
Yes.
Good. Whenever we say squamous, mean flat. Squamous part of temporal bone, flat part of temporal bone. Squamous part of occipital bone, flat part of occipital bone. Okay. Here we have two important structures: mastoid process and styloid process on this region. Here is styloid process and here is a mastoid process. Why I'm saying you? Because in between them is a foramen, stylomastoid foramen. Stylomastoid foramen. Okay? Can you identify this here now? Carotid canal and jugular. And without esophagus. Till many days you have to remember. Okay. Now, along with the foramen magnum in the occipital bone, this is the all occipital bone, along with the foramen magnum, we have a condylar process. Condylar process is an elevation which is fairly visible. I will show you in a minute here. This is for making the first joint between the cervical first vertebra and the skull. Okay? So this condyle has on its anterior end here and here hypoglossal canal, condylar canal. Hypoglossal canal and condylar canal. This should ideally be said as foramen because they don't have a very good, but since the name nomenclature is like canal, so here this is the condyle, this is all occipital bone, this is the foramen magnum. Just on its side we have two condyles, one here, to make the joint with the first cervical vertebra. Okay, the first joint. Now here in front, anterior laterally or almost in front, we have hypoglossal canal, and on the back we have condylar canal. Don't worry, I will be able to show you all these with the passage of a pin inside after we finish. Yes, this is a sort of revision slide, and you can see a lot of structures, lot of things here. Almost whatever I have said, you can revise here now on the basal. So here is incisor foramen, greater palatine, lesser palatine, choana, back of the nose, zygomatic arch. Okay, then the smallest, spinal, oval, ovale. On the medial side, lacerum. After that, carotid canal. You cannot see through the carotid canal here in this good picture. All of them, they are visible. Why? Because the carotid canal has to turn inside while going up on the front. Then we have this one, jugular foramen. Excellent. Then we have styloid process and a mastoid. Between them, stylomastoid. Then we have foramen magnum. Then we have a condyle, and here hypoglossal and condyle. Anything we left? I think no. This is the flat part of occipital bone, and of course this is the alveolar arch. This is one of the view where we can see a lot of them, but just making some of the positional change in the images. I will show you more things in a minute. What is anterior cranial fossa, middle and posterior cranial fossa? This is now I am in the interior of the skull. I am inside the cavity, okay? We have removed the vault. Here was the vault. We removed it, and now I can see the cavity. Remember one thing. Here is the anterior boundary of anterior cranial fossa. Here is the posterior boundary of anterior cranial fossa. Good? Now, this is anterior. When I say middle cranial fossa, the same boundary, the posterior boundary of anterior will make anterior boundary of middle. And here is the petrous rough part of temporal bone, rough ridge-like structure. We can feel it later on. This is petrous part of temporal bone. So the middle cranial fossa has a boundary. Here anterior boundary, here posterior boundary. Made by what? The posterior boundary of anterior. Similarly, for the posterior cranial fossa, we have anterior boundary which was actually the posterior boundary of middle. So the boundaries are same. You have to remember only once the three structures or four structures: frontal bone, lesser wing of sphenoid. Mind you, greater wing is here. Leave it for a while. So this is again frontal bone, lesser wing of sphenoid, petrous part of temporal bone, and the occipital behind. If you remember 1, 2, 3, 4 landmarks, you know the boundaries of all anterior, middle, and posterior cranial fossa. Good? Easy?
Easy.
Vishal. Okay. Where should be the floor of this fossa? Suppose this is anterior cranial fossa, like this. Where should be the floor? This bone is the floor. Where is the roof, Alex? Where is the roof? Of course, by the frontal bone. So you should make imagination that this is the floor, anterior cranial fossa, middle cranial fossa, posterior cranial fossa, the floor. And you know some of the landmarks and you are through. Okay. Here we have anterior cranial fossa is magnified here, the blue one. Here frontal bone. Here lesser wing of sphenoid. This is all sphenoid bone, the yellow. Here, here, and here. This is body of the sphenoid, which is going to have a pituitary fossa, sella tracheica, hypophyseal fossa, all the same names. Pituitary fossa, better to remember. Then here's the body. Even in the body, if I go deep into this fossa, remove some chiseling the bone, I will land up into a sphenoid air sinus. There are two. One from here, with a small septum between them. So here is one sphenoidal sinus, another sphenoidal sinus. Never confuse the sphenoidal air sinus with the pituitary fossa. I will show you some pictures later on. So, where are we now? This is anterior cranial fossa. Anterior boundary, posterior boundary, lesser wing of sphenoid. This is the floor. Made by what? This is the frontal bone. This is the orbit. So orbital plate of frontal bone. Okay? So orbital plate of frontal bone will make its floor. Here you can see another fissure. Here. Inside the orbit. This is inside of the orbit if I see from the front. We have multiple other pictures to show you. Then, okay, here is called as optic canal. For optic nerve, this is the orbit. Here is the eye. Then we have an optic nerve. Get out here into the skull. Here is another optic canal. Forearm, another eye. And you know they make a cross section.
Common to these.
Optic chiasma. So here they are likely to make optic chiasma, connection between the two. And for the passage of this part of the nerve and this part of the nerve, we have a depression, sulcus chiasmaticus. I will show you multiple pictures, inshallah. Are you with me?
Yes.
Comfortable? So here is sulcus chiasmaticus. I will repeat it. Okay. This is called crista galli. What is crista galli? It is an elevation of the bone. Which bone? Ethmoid. This is ethmoid bone. Here is frontal. Here is ethmoid bone. This is crista galli. Crista galli is an elevation for the attachment of forks, which is one of the meninges. On a side view, you can find this as crista galli. This is the crista galli. And this is the sphenoid bone. And when you were very small, we used to teach you the nose, showing you the lateral wall of the nose has 3 turbinates or the concha, superior, middle, inferior. And now you should remember that ethmoid bone contributes to this superior concha or turbinate and middle concha or the turbinate. So this is the same. Cribriform plate of ethmoid is this structure. Why we say cribriform? Because there are some small openings. Why the openings are there?
Question.
Olfactory nerve.
Again.
Olfactory nerve.
Olfactory nerve, yes.
That's a clinic question.
The olfactory nerve has a bulb first. Suppose this is the olfactory nerve. This blue is the bulb of olfactory nerve. It has some roots going down. So these branches needs an opening. So these are multiple openings, now called as cribriform. When we have any fascia with multiple openings, small or like bone, we call this structure as cribriform. This is called as cribriform plate of ethmoid. Plus we have anterior ethmoidal canal roughly at this stage and posterior ethmoidal canal roughly at this stage. For passage of anterior and posterior ethmoidal arteries and nerves which are there for the other sensations of the nose rather than olfaction. So olfaction is with the olfactory nerve and the cribriform plates. Cribriform plate is for olfactory. And the two other foramen, anterior and posterior ethmoidal canals, are for anterior and posterior ethmoidal arteries and nerves to give other sensation into the nose except the olfaction. Okay. Here we have many structures to identify. The yellow all is sphenoid bone. So here is the body of sphenoid bone. Here is the lesser wing, here is the greater wing. All this is greater wing. You can even find lacerum, ovale, spinosum, ovale, lacerum, carotid, canal maybe, and jugular. Here is the rough petrous part of temporal bone, making now the boundary of posterior boundary of middle cranial fossa. Here is all sphenoid bone. This star is known as dorsum sella. We have multiple structures here. Let's see another slide and it will show you a lot of them. Yes, this slide is good for understanding. See first the pituitary fossa or hypophyseal fossa or sella trashica. Okay, in front of it there is a ridge-like here. Before that, here is the optic canal, another optic canal with a sulcus chiasmaticus, and here is the point where the two will make a chiasma. And remember always that this chiasma is in very close approximation of the pituitary gland. Any enlargement in the pituitary gland is likely to compress on the chiasma, and there is bitemporal hemianopia. The two sides of the vision, on the two lateral sides of the vision, are going to be affected. Bitemporal hemianopia. This is number one. Then we have tuberculum sella, the anterior ridge-like structure. Tuberculum sella, the posterior ridge-like structure. Dorsum sella, making a saddle-like. This is a tuberculum anteriorly, dorsum sella, here tuberculum sella, and here is the pituitary fossa actually. And if I go deep to this pituitary fossa, here there is a thin plate of bone, and after that there is a sphenoid air sinus, of course two in number, one for the right and left, and of course there is a septum between them. So this is pituitary fossa, here is the septum, here is one sphenoid sinus, here is another sphenoid sinus. Are you with me?
Yes.
Good. Yes, this picture is just to show you how clinically on X-rays you find pituitary fossa and how you have to differentiate it from the sinus. Here is the crista galli. Here is sphenoid air sinus. In the sphenoid bone, where is sphenoid bone? All this is sphenoid bone. This is pituitary fossa, and the red structure is pituitary gland. This is the side view, and this all is Fox, one of the meninges you will learn in the next week maybe. Here is the pituitary fossa, anterior boundary, posterior boundary, dorsum sella, and this process is known as anterior clinoid process, and this is known as posterior clinoid process. Some of the books say middle clinoid process. Maybe this one. But forget it. Anterior posterior is enough. Another thing, what other structures you can see here? Yes, optic canal, sulcus chiasmaticus, spinosum, ovale, must here be lacerum. Now here you can see in a different angle, you can see a new foramen here, rotundum. Rotundum. Foramen rotundum. This is the back of the orbit. This is the orbital cavity. So you can see here one superior orbital fissure, or here superior orbital fissure. Of course, there is an inferior orbital fissure here. I will show you in another picture. Don't be confused here. The main importance here is you can see frontal bone. You cannot see the contents, of course, because it's a bony appearance. But air, here is the frontal air sinus in the frontal bone. Can you imagine this number 1 is the pituitary fossa. Here is the boundary of pituitary fossa. You can even see clearly anterior cleanoid process, posterior cleanoid process. And this black sphenoid air sinus sometime may be divided into two parts, like area, white area, bony area you can see. So all number 5 is sphenoidal air sinus and number 1 is the pituitary fossa. When I have to operate upon the pituitary gland, I should remove the vault, the whole brain, remove the pituitary gland, put everything back. Not possible.
Transphenoid.
Go through the nose, transsphenoidal approach. This is called transsphenoidal, going through the sphenoid. So here is the nose. I approach from here, go into the sphenoid sinus and then go to the pituitary. Don't try at home. Don't put anything. Okay? Please don't try at home. You need a lot of skills to know it. Are you with me?
Yes.
Good. Thank you for the attention. Okay. Middle cranial fossa, you know most of the things now. Superior orbital fissure, yes. Foramen rotundum, yes. Trigeminal impression, leaf, tegment. Okay. What is petrous part of temporal bone? This rough is called petrous part of temporal bone. It's very easily detected and palpated on a real skull or a model. So petrous part of temporal bone. It has, here is the level of ear. For there we have a external acoustic meatus, this one. External acoustic meatus, there is the ear. On the inside of this petrous we have an internal acoustic meatus roughly at this stage. We have other pictures to show you. Here is external ear, middle ear and internal ear. If I remove some bone, I will find the cochlea of the inner ear like this. So this is the petrous part of temporal bone. From the inner ear, we have vestibulocochlear nerve to get out, get towards the brain. And this is the opening for that. Internal acoustic meatus. Acoustic yani related to ear. Internal acoustic meatus. Nothing new. Okay, just a quick revision here. Now this is the true interior of the skull. What do you see here? Optic canal, sulcus, pituitary fossa, anterior boundary, posterior boundary, anterior clinoid process, posterior clinoid process, here, here. Spinosum, ovale, lacerum, rotundum, magnum, petrous part, internal acoustic meatus, very clear here, and this smooth part for pons and basilar artery is called clevis, a special name, clevis, a bony name, name of the bone, not the opening. Posterior cranial fossa, here is the anterior boundary, the petrous part, here is the occipital bone, posterior part. Median area, of course you know now, clevis, foramen magnum, squamous occipital, the flat part of the bone with 2 stars, lateral area, petrous temporal rough. Okay, there are some impressions, not foramens. So I'm not going into details because impressions are not with you. Here is like a depression, and they are following the route of or the pathway of the sinuses. Remember, there are two types of sinuses in the brain. Air sinuses, 4, frontal, ethmoidal, sphenoidal, maxillary, 4 air sinuses, to make your skull light. Even if this is very light, and if this was no air sinus, by the evening I must hold my head and go like this. So they give you a resonance to your voice. This the air sinuses. Then we have venous sinuses, dural venous sinuses, which are inside the 2 layers of dura mater. We will teach you in the next when we have meninges with you. Frontal view, just to show you the frontal. Yes, here you have a lot of structures to identify. This is the orbit. Outer to orbit here, notch or a foramen, supratrochlear or supraorbital, infraorbital in the maxilla. Now here you can see multiple structures. You can see the perpendicular plate of ethmoid for the nasal septum, and you can see the vomer for the completion of the septum. You can see inferior concha, middle concha or turbinate, and of course here should be the superior. This is nasal bones, 2 nasal bones. Inside the orbit, what you can see, this one, superior orbital fissure, inferior orbital fissure, and optic canal. So here is the eyeball, optic nerve will enter. On a different angle, even you can see rotundum. I will show you later on. All what I said you, superior orbital fissure, inferior orbital fissure, everything pointed here. Yes, my job is finished. Your job starts here. This is, you have to remember, I cannot teach you this. You have to remember and recall yourself. So I have tried to make all the list. If something is missing, please add and tell me also. Fractures of the skull are very common due to trauma, road traffic accidents, or fights, street fights. Very common. So they can be depressed fracture like this, compressing on the brain. They can be through and through fractures on the base, which are very dangerous really. So you can have some degree of associated symptoms because it's very hard to diagnose the fracture on the base of the skull. It looks very simple on the picture, but it's very difficult. Associated signs may be in the posterior cranial fossa, a blood or a bruise on back of the ear known as battle sign, the fight sign. Sometimes we have CSF rhinorrhea, CSF trickling out of the nose, or we have CSF otorrhea, CSF trickling out of the ear. So these are associated signs with the fracture of base of the skull. In frontal, we can have this condition called as black eye. This is a bleeding tendency in near and giving you an impression like. Any questions up till now? Sorry.
I think it's Doctor, it's kind of revision for us.
Yes, I make it a sort of revision. Otherwise, if I directly tell you this is foramen lacerum, you are like lost. So I just try to recapture most of the things and then put the foramen and fissures. This is again a revision. I have done most of the things with the spinal cord. Okay? Just a quick revision for the parts of the vertebra body, then pedicle, then lamina, spine, and 2 transverse processes. Vertebral foramen. When all the vertebral foramen, they are placed in a consequences in a sequential manner, they are called as vertebral canal. What is vertebral canal and where it is here? Inside and here, of course. Vertebral canal contains the most important is the spinal cord along with its coverings, blood supply and everything. From the spinal cord we have emergence of nerves at spinal segments. What is that? From where? Intervertebral foramen. This is the point. The nerve trunk is here. After the vertebral foramen, we usually have anterior division and a posterior division. How this foramen is formed? This is by the contribution of two adjacent vertebrae. Half from here and half from here. When they join, they make this structure intervertebral foramen. Here are of course the spines and other structures not related here. Okay, what is vertebral canal? The other name of vertebral canal is spinal canal or spinal cavity. Is the canal that contains the spinal cord in the vertebral foramen and the vertebral column backbone when we make them sequential arrangements. Here is the vertebral foramen. Here it's with all the contents of the vertebral foramen or the canal, spinal canal. You know this. Vertebral canal, this is the sequence of in a sequence. Outer to inner. Extradural space, outer to the dura mater. Then subdural space, a small potential capillary space. Then arachnoid matter. Then subarachnoid space. Then pia mater. And you know some book says pia mater has different layers, I will tell you. Spinal cord and cardiac vein. Here is a big picture to show you. Yes. This is the vertebral canal. And you can see how nature, Allah subhanahu wa ta'ala has placed all these fine things in such a small area, controlling us the whole life. Here is the spinal cord. This white line is the pia mater. Here is the dura mater and arachnoid, this one. Dura and arachnoid, both. Remember, the dura and arachnoid, they cover the spinal nerves to some extent. So, the CSF, a very trivial amount, small amount can even be present here. So, dura and arachnoid cover some part of the spinal nerves before they exit through the intervertebral foramen and they have anterior and posterior divisions. Okay, here. Again, here you can see. Plus, you can see outer to the dura. Here, outer to the dura, some veins. Internal vertebral venous plexus, I told you in details with the spinal cord. This picture you are familiar with, and you know the parts of pia mater. You know it has a filum terminal, which is this is the spinal cord conus. Here is the conus medullaris, and after that a thread-like structure comes out. This is on all the sides. This is pia mater to hold the spine. This is because the cord is like a jelly-like structure. I have sent a video for that to the leader. I have already sent, showing the jelly nature of the brain. He must send you, or he must have sent you, I don't know. Then you know about ligamentum denticulatum, subarachnoid septum, and linea splendens. I have done with the spinal cord. Is there any need to do it again? No. Here, ligamentum denticulatum, just a quick. Ligamentum denticulatum, linea splendens here, and the subarachnoid septum. All they are made up of pia mater. Extradural space, loose areolar tissue, fat in a semi-liquid form, spinal arteries, and internal vertebral venous plexus. This one are the contents of extradural space outside the dura. Dura mater is one of the thick layer. You know most of the characteristics. The most important point here to remember is in nearly S2, it is the ending point of dura and arachnoid both, of course. Subarachnoid capillary potential space is contained a thin fluid for free movements and to reduce the friction. Space is continued for a short distance on the spinal nerve. I told you this one and I explained to you. Arachnoid matter is the second transparent thin layer and ends along with the dura at S2. After that, it contains subarachnoid space, and that is a suitable place for us after the finishing of conus medullaris at L1 level in adults. We can have a lumbar puncture, you know all the sites. Pia mater, along with other structures, we have epipia, inner pia, and inner pia is the one which is very closely attached to the ligamentum denticulatum and all these structures you know. Last night I received a call, what is cauda equina? So here is the definition of cauda equina. Bundle of spinal nerves and spinal nerve rootlets after L2. L2 including 3, 4, 5, L, then S1, 2, 3, 4, 5, all S, and then coccygeal. They arise from, here is the conus medullaris. From here, they make a bundle, and this bundle is called cauda equina, floating in the CSS. Here is another illustration for just to remember the layers: bony layer, dura mater, arachnoid mater, pia mater. Okay. Extradural space, subarachnoid space. Pia, you can see the two layers thickening, one attached to the spinal cord and one extra for making these extra structures. I have shown you this picture before in spinal cord, just to quickly showing you what is the objective of this picture is to just make an imagination of dura, arachnoid and pia, and then what are the spaces related and what are the contents. You know this all. Okay. Most of the new names were here today. So this will help you to go through the names and their locations. I have multiple pictures to show you all of them. Thank you very much.
Thank you.
I will welcome your questions here, inshallah.
Thank you.
Thank you.